Okay, let's just take a deep breath. I know that big unit exam is looming, and that last-minute study crunch is no joke, but seriously, you've got this, and we're gonna get through it together. You're staring at that study guide, right? And it just feels like this endless list of drug names, crazy side effects, and concepts. It is totally normal to feel like you're drowning in information. You're probably thinking, where do I even start? Well, you start right here. We are going to slice through all that noise and focus on the absolute high-yield must-know info. Think of this as your exam prep power session. So here's our game plan. We're going to tackle this in 3 quick parts. First, we'll master the diabetes drug playbook. Then we'll arm ourselves with the anti-infective arsenal, and we'll wrap it all up with Medication Safety 101. Ready? Let's do this. All right, first up, the diabetes drug playbook. I know this is a huge category, so we're going to simplify things and really zero in on the core medications and principles that you're pretty much guaranteed to see on your exam. Before we even get into specific drugs, we have to nail this concept down cold. An agonist? Think of it like the right key for a lock. It goes in, it turns, and it starts the engine. It activates something. An antagonist, on the other hand, is like a key that fits in the lock but just gets stuck. It blocks anyone else from using it. Simple, right? But it is so fundamental to everything else we're about to talk about. Okay, so here are the major players. You've got Metformin, which is the classic go-to, the first-line therapy. Then you have the SGLT2 inhibitors, and here's a tip. Look for that flozin at the end of the name. That's a huge giveaway on an exam. Next up, the GLP-1 agonists, which we call GLP-1s. And yep, they are agonists, just like we discussed. And of course, the big one, insulin, which is an absolute essential hormone. And speaking of insulin, let's just lock in the basics. For type 1 diabetes, it's completely non-negotiable. It's life. It's given either by injection or more and more by an insulin pump. And you've got different types, rapid, short, long-acting, all for different timing needs. The main takeaway, the dosing is incredibly precise, and getting it right is beyond critical. So let's think about this for a second. We're giving all these powerful medications to lower a person's blood sugar. So what's the logical flip side? What's the biggest, most immediate danger we need to be watching out for? You got it, hypoglycemia or dangerously low blood sugar. This is where you have to know the rule of 15s. It's brilliant. If your patient is shaking, sweating, or confused, you give them 15 grams of fast-acting carbs. Think a little bit of juice or some glucose tablets. Then you wait 15 minutes and you recheck their blood sugar. Once they're stable, you follow up with a real snack or a meal to keep their levels from crashing again. This isn't just a test question. This is a life-saving skill. Okay, now here's a huge clinical pearl, a real pro tip for those GLP-1 agonists, the GOP1s. If a patient taking one of these drugs complains about severe, deep stomach pain that just won't quit, your brain has to scream pancreatitis. It's a very serious and very testable adverse effect. Don't forget it. And of course, we can't talk about pharmacology without talking about interactions. This is a big one. Beta blockers, which are super common, can actually hide the warning signs of low blood sugar, like a racing heart or shakiness. That's dangerous. And then on the flip side, you have other common meds like steroids that can actively jack up blood sugar, basically fighting against the diabetes meds. You have to be watching for both of these things.
Thanks for watching. Enjoying the content? Like, share, and subscribe for more. Now back to the video.
All right, great job. Let's switch gears. We're moving from our diabetes playbook to our anti-infective arsenal. These are the tools we use to fight off all the bad guys. Bacteria, fungi, viruses, you name it. But before we even list a single drug, we have to start here. This is the why. Why are we so careful with these medications? It's because of antibiotic resistance. The bacteria are literally evolving to outsmart our drugs. This is a massive global health threat. And using our arsenal correctly is the only way we stay ahead. So here's a quick look at the lineup. We have sulfonamides like Bactrim, which are workhorses for UTIs. There are the Fluoroquinolones, and hey, another suffix for you, floxin. For fungal infections, you want to look for that azole suffix. And for a really tough bug like tuberculosis, or TB, one of the big guns is a drug called Rifampin. We're going to talk a little more about that one. Oh, and just a real quick heads up because this trips up so many students. If you see Bactrim on your exam or you see TMP/SMX, they are the exact same medication. One's the brand name, one's the generic. Don't let it throw you for a loop. Okay, let's put Rifampin under the microscope for a second. For TB, it's a cornerstone drug, but it has some really unique, really testable quirks. First, it has a ton of drug interactions, so you have to be careful. And second, and this is the classic exam question, it turns body fluids like urine, sweat, and even tears a reddish-orange color. It's harmless, but if you don't warn your patient, they will freak out and stop taking it. So patient teaching here is absolutely critical. And just a quick general reminder that applies to pretty much all antibiotics. An upset stomach or GI issues are super common, and you always have to be watching for any sign of an allergic reaction, from a simple rash to something much more serious. Okay, we've covered the drugs. Now for what is honestly the most important part of all, how to give them safely. This section is where we tie it all together, because knowing what a drug does is useless if you don't know how to administer it without causing harm. I absolutely love this quote from the source material because it's just so true. You can't get around it. You have to be good at dosage calculations. Being accurate isn't just, a nice goal. It is the absolute bare minimum standard. Your patient's life literally depends on you getting the math right every single time. Now, thankfully, technology is our best friend here. The process is so simple, but it's incredibly powerful. You scan the patient's wristband, you scan the medication's barcode, and if that computer system flags any kind of discrepancy, any mismatch at all, you stop. Full stop. You don't guess, you don't override, you stop, you figure out what the problem is, and you resolve it. So let's just circle back and hammer home two of those high alert interactions we've already touched on. Mixing some antibiotics with blood thinners can seriously ramp up the risk of bleeding. And like we said, giving beta blockers with diabetes meds can dangerously hide the warning signs of hypoglycemia. These are combinations that should make your internal alarm bells go off. Phew, okay, we covered a lot. So let's do a rapid-fire recap. Here's what you need to take away. Know your suffixes, like flozin and azole, they're free points. Watch for the signs of hypoglycemia and pancreatitis. Understand that antibiotic resistance is a very real threat. Double, even triple check your math and potential interactions. And never, ever ignore a discrepancy. These are the things that will keep your patient safe and nail you those points on the exam. And really, that brings us to the final and most important point of all. Knowing all these facts, that's just step one. The real test isn't on paper, it's at the bedside. The barcodes, the checklists, the computer systems, those are all just tools. But you are the final, human, critical thinking safety net between that medication and your patient.
Enjoyed this video? Please like and subscribe. It helps the channel grow, allowing more content for you. New videos weekly. Thanks for watching.